a totally different type of thing that's up and coming, because we see a lot of you with sleep issues when we do our sleep studies. He got his BA at the University of London and his medical in Cairo, at the University of Cairo. And he's done his residency in pulmonary and critical and sleep fellowship at USC. We're very honored to have him here today speaking to us on COPD and sleep. Thank you, Dr. Atwell.
So if anyone falls asleep, I totally understand it's after lunch. It's happened before, so it's okay.
It's after lunch.
Oh.
Okay, is it get going on? Oh, there you go. Okay, let me turn off a little bit of the lights here too as well, so we can see a little bit better.
So I'll be talking about sleep disorders and a little bit in particular to COPD patients. Sleep disorders are a huge subject and we can spend days and days and days talking about it, so I'll try to pick sort of what's pertinent and important, and if you have any questions afterwards, I'll be happy to answer that.
Could you hold the mic a little closer to your mouth?
Okay.
Thanks.
Thank you.
Thank you. I think you advanced it within, there you go.
So I'm sure you all know what COPD is. It's a condition where there's airflow limitation. The airways, which are nice and wide, become narrow, full of mucus, and you can see the parenchyma at the end. Instead of having nice air pockets for oxygen to diffuse through, they become sort of large and flabby. This is just an introduction. There's a lot of comorbidities that happen with COPD, and there's a whole bunch of them, and I'm sure you all know those more than I do. But at the end, I'll be talking mainly about the sleep disorders, which happen to be very frequently occurring with COPD patients. So with sleep disorders and COPD, we see a whole number of them. The most common would be the top one there, which is the sleep-related breathing problems, which is a totally separate set of breathing issues that happen at night in COPD as opposed to regular people, and in addition to the COPD itself. Also, I'll be talking about insomnia, just difficulty either going to sleep or staying asleep or waking up early and then going back to sleep again. And then it's always nice to remember that COPD are also regular human beings, and they have all the other symptoms that can come, or all the other disorders that happen with sleep. And we see a whole bunch of them, like abnormal movements at night. We see restless leg syndrome that happens frequently, a lot of other conditions that I'll not be talking about today. The sleep-related breathing problems, we see that in about 40% of people with COPD particularly. So it's a large number of patients. And insomnia happens in at least a quarter of the population. So I'll start with insomnia, which is probably what most people are interested in. And that the definition here is either difficulty falling asleep, so you go to bed, lie in bed, watch the clock for hours, or you wake up in the middle of the night and you just have a hard time falling asleep again, or you just wake up too early before you're ready to wake up and you just lie in bed and not being able to get up. As I mentioned, about 25% of the people do that, and I'm sure this picture is very common, lots of households just sitting there watching the clock. I've done that myself many times. There's a lot of reasons, particularly in COPD, to do that. So some of the symptoms of COPD, such as cough, if you're coughing a lot, you'll have a hard time falling asleep. If you're short of breath, you'll have a hard time falling asleep. Some of the medications we use for COPD do cause insomnia. They are stimulants, and when you take them at night, they will prevent you from falling asleep. Very frequently, as I mentioned, the breathing issues that happen at night are present in about 40% of the patients. So it's not unusual to have, in addition to that breathing issues that will prevent you from falling asleep. And also very important to that is other medical issues that happen with COPD, particularly anxiety and depression. Sorry, went under the picture there. But anxiety and depression are quite common in COPD, and those in themselves can cause a lot of insomnia. In fact, it is estimated that at least 40% of insomnia patients as a whole have either underlying depression or insomnia, or anxiety. And it's very, very difficult to get someone to sleep if they're feeling sad or anxious. Just the fact that you go to sleep, sometimes just anxious about falling asleep. The whole idea of going to sleep makes you really anxious. People start thinking about it hours before bedtime starts. That in itself will prevent you from falling asleep. I've had patients tell me, I'm sitting on my couch in the living room, feeling fine, starting to feel drowsy, I can almost fall asleep, but the moment I go to my bed, it's like someone turned the switch on, I'm wide awake, and then they start being very anxious about that. So that is a very common condition. If someone does come with insomnia, and we always try to rule out the breathing issues because it's a very common condition, and if that is the case, we should do sleep studies for those patients, and I'll be talking about that separately a little bit later on. The main treatment for insomnia is something called behavioral and cognitive treatment. This is a therapy that has been proven to work, but it needs a lot of sort of education and structure. So it's a way that you structure the day and the night, making very specific bedtime and wake-up times, and you structure the going to bed in a way that allows the sleep to happen. Sometimes we add medications to that as well, but mainly by going through this structured program, people are able to sleep and stay asleep well. And it's been proven to be the most successful way to treat insomnia. I myself don't like prescribing medications for insomnia. They have a lot of problems associated with them. Most common, of course, is you get very dependent on these medications. But in particularly with COPD, they do cause a lot of side effects. So they are suppressants, they're downers. So sleep aids in general will suppress your breathing. They will cause you to be more hypoxic, drop your oxygen level at night, and can decrease your respiratory drive, and also cause some muscle diaphragmatic problems that can affect your breathing at night. So particularly in patients who have breathing issues, we try to avoid sleep aids. If we have to use a sleep aid of some sort, we prefer antidepressants. As I mentioned, the antidepressants in themselves do have a sedating quality, so they can help you fall asleep. In addition to that, depression is very common as a cause of insomnia, so adding the antidepressant helps quite a bit. And it helps calm down the anxiety as well that can happen. Melatonin we use frequently in these situations, as well as gabapentin can also help. These have less side effects than the traditional sleep aids. I'm going to talk a little bit about what we call a sleep hygiene, or sort of what rules you should, and this applies to the majority of people, but generally this is what we all should do to be able to sleep well at night. So most people, when I ask them what time do you go to bed and what time they wake up, they tell me, well, I start by sleeping on the couch and I sleep there for an hour or so, and then I get up and I go to bed. So I usually go to bed anywhere between 10 and midnight. So it's a very long, vague time. And when you wake up, well, I wake up anywhere between 7 and 10 in the morning. Again, a very long time. And it's very important to have a very specific time where you go to bed and a very specific time when you wake up in the morning. One of the most common complaints I see in the office is someone who comes to me telling me, all my life I've been working so hard, and I wake up at 6 o'clock in the morning, and I've been looking forward to the day I retire so I can sleep in. And now that I'm retired, I'm sleeping in, I can't sleep. I can't stay asleep. And the problem here is that poor sleep hygiene. You're spending more time in bed. Instead of waking up at 6, now you're waking up at 8 or 9, or spending 2-3 hours awake in the morning, and that causes the insomnia to occur. And my solution is go back to doing what you were doing when you were working, and that usually works. So standard wake-up time is very important, and that time should be the same time whether you're off or working or any time. Using the bed only for sleeping is also very important. How many of you watch TV in bed? Everybody? Read in bed, work, computer work. I have a patient of mine, this is a true story, who just could not sleep. And I find out that she owns her own business, and she comes home, does a lot of work at home. She just brings her lunch and sits in her bed. She eats in bed, works in bed, everything in bed, and then come at night, she can't sleep. So she turned her bedroom into her life, her works. And just by asking her not to sleep, not to do all that in her bed, it made her very anxious. And she told me, no, I picked out the best bed, the best furniture to be able to make this bedroom the way it is. So we compromised in her sleeping in a different room, and that became her work office. And by doing that, she was able to sleep. So sleeping and using the bed only for sleeping is very important, and this is what we call conditioning, which I'm sure you're all aware of that. Who remembers Pavlov's experiment? Yeah, exactly. Of course, you would know that. So he had a dog, and he would give the dog some food and ring a bell. And every time he would do that, the dog started learning that ringing the bell is going to give him some food. So after a time, just ringing the bell alone, the dog would start salivating. Well, our brain does the same. So going to bed is a very strong stimulus to go to sleep. But if you go to bed to read or watch TV or work or eat, then the brain becomes confused. Am I here to be awake or am I here to sleep? So it becomes very difficult to decide to go to sleep at that time. And if you wake up in the middle of the night, you're already used to watching TV to be able to go to sleep. So if you wake up in the middle of the night, you don't know how to go to sleep again without that TV. And I have many people who just leave the TV on all night long, just so that when they wake up in the middle of the night, they're able to go to sleep. When my daughter was very little, she couldn't sleep without her pacifier. And then she would wake up in the middle of the night and the pacifier falls out of her mouth, and she couldn't find it, so she would start crying, because she does not know how to fall back asleep again. So I corrected that problem by putting about 10 pacifiers in her crib. Yeah. But that is the problem, and we're actually now teaching parents not to feed the kids to go to sleep. So because if they learn to only fall asleep when they're eating, they will not know how to go to sleep on their own. Get up when you can't sleep is also along the same line. So if you're not able to sleep, if you're just lying in bed for 2 or 3 hours, all that does will make you frustrated. So if you can't sleep, you get up and use those couple of hours for something else. Worrying, planning, and so forth in bed, that's sometimes a little bit hard not to do. If you're lying in bed, things come to your mind. We all do that. So I always tell people, if that does happen, just get up and leave the room. Do something somewhere else, start reading, watching TV somewhere else, and then come back when you're ready to sleep. Daytime napping is sort of controversial. Does anyone here nap? Everybody. Okay. And the people who raise their hand, do they have trouble sleeping?
No.
Okay. Some. And that's why I said it's controversial. If you look at literature coming out of Europe, napping there is totally normal. Everybody naps there. Over here, napping is sort of frowned upon because of the way our day goes around. It doesn't allow time for napping, especially if you're working. So, but what we do know is that napping during the day does take up part of the sleep. So what I tell people to do is, the amount of time you need to sleep has to include that nap. So if you're a 7-hour sleeper and you nap for an hour, well, only expect 6 at night. And if you do nap later in the evening, it will interfere with your sleep at night. And the last one is sort of makes sense, but a lot of people don't follow that, which is go to bed only when feeling sleepy. A lot of people go to bed because they're done with the day. There's not much else to do. There's no one to talk to, there's nothing on TV, so I'll just end my day, I'll go to bed. And if you're not ready to sleep yet and you lie in bed, well, if you can't sleep, you'll lie there frustrated. And then it becomes a habit, you get more and more tired, and you end up going to bed earlier and so forth. So these are sort of general rules to help you sleep. I was going to take a picture of my son's room, but he wouldn't let me, so I just picked this on the internet, but this is what it looks like. It's very important to have a bedroom that helps you sleep. So having a neat bedroom is very important. Dark is very important. So a lot of the shades that people use don't really keep the bedroom dark. It's very important to have a really dark room and a little bit on the cooler side. These are all ways to help the bedroom, help you sleep at night. Avoiding steady use of sleeping pills. Again, I'm not a fan of sleeping pills. Smoking at night, is a stimulant. Caffeine at night. I'm sure a number of you drink coffee at night. A lot of people do. That is actually does interfere with your sleep at night. A lot of people tell me I drink my coffee and I still sleep okay. What ends up happening is that they're so tired that even though they drink the coffee, they're still able to sleep, but it does interfere with the sleep at night. All right. So we'll move on to the sleep-related disorders. Any questions about insomnia before we move on?
You had mentioned one, if you're a 7-hour sleeper, 8 hours, how many hours of sleep should we get on an average night?
That's a very good question. The average is about 8 hours, but that's an average. In my office, I have people who only need 3 or 4 hours, and I have people who need 10 or 11 hours. So the way I answer that is the number of hours you need is what makes you feel good during the day. On average, most people are between 7.5 to 8 hours. And again, you have to factor in any sleep during the day. So if you sleep an hour or 2 hours during the day, that's part of your quota for the day. Oh, go ahead.
What about after eating dinner?
What about it?
Sleeping after eating dinner and then trying to go to sleep later on at night.
Well, so that is a big problem. So if you sleep after eating dinner, that tells me that you're sleep deprived. The fact that you're falling asleep, that means your sleep at night needs to be evaluated for some reason or other. You're not getting refreshed from your sleep. And if you do fall asleep after dinner, that is going to affect the way you sleep at night. It's going to cause some insomnia at night as well. You may not be able to fall asleep well. So if people shouldn't fall asleep after dinner, but if they do, one of the biggest issues we usually look for is some sort of disruption to your sleep, and the most common is probably sleep apnea that I'll be talking about later. Yes.
I recently heard that using a weighted blanket would help you sleep better.
Sorry, say that again?
I recently heard that using a weighted blanket might help you sleep better.
Can you repeat the question?
So using a weighted blanket will help you sleep better. So it depends on what you like. There's no evidence to say that would work. I can tell you in my house, I don't like blankets at all. My wife uses 3. So it depends on what you prefer. There's nothing about that would make you feel better except if it makes you comfortable.
How about stimulants like music?
Repeat.
He's asking about stimulants such as music. Why do you call it a stimulant?
Because it may help you go to sleep.
So using what we describe as white noise to take your mind off the fact that you're trying to go to sleep helps quite a bit, yes. And that is something that we do advise people to do.
I listen to the news and that puts me to sleep.
Well, the concern with TV is 2 things. Well, 3 things actually. One is the conditioning that is unable to go to sleep without listening to the news. So if you do wake up in the middle of the night, you'll have a hard time falling asleep again. 2, the TV does emit a light that is what we don't like seeing in the bedroom. And 3, the problem with TV is that the news is monotonous, and that's a good white noise to hear. But then you get commercials in the middle that usually have a very loud noise, and those are very disruptive to sleep. All right, so we'll move on to sleep breathing disorders, and there's a number of them that we see particularly in COPD. One of them is sleep-related hypoxemia. That is your oxygen level dropping at night. If you see in that graph, this is sort of in the middle of the night, and the oxygen level at the beginning, this person is still awake with a good oxygen level. And as the night progresses, his oxygen level keeps dropping. Now that could happen just because of the COPD, but it could also happen because this person may have sleep apnea as well. Very frequently we see this happening with drop in oxygen level during the day as well, but there are some times that we see it only at night, and I'm sure we've all seen that, where your oxygen level only drops at night and not during the day. We see this in 70% of people with COPD, a huge number. And the more severe the COPD, the more this occurs. The opposite is also true. We do see increasing carbon dioxide. That happens in only about 10% of people. And again, this is during the nighttime, and you can see the oxygen level trending, the CO2 level trending upwards as well. And these patients usually have, if you check their blood gases during the day, it's usually normal, but at night the carbon dioxide increases. We see something called the respiratory effort-related arousal. It's a long term, but what that means is that because of the effort to breathe at night, you keep waking up. So you fall asleep and you're having a hard time breathing, and because of that increased effort, you wake up to breathe. What that does is fragments your sleep, so you don't get a whole lot of rest out of your sleep. The more severe the COPD is, the worse that is. It has something to do with the breathing mechanics and so forth. And the symptoms are very similar to symptoms of sleep apnea that I'll be talking about in a second.
Doctor?
Hello.
Yes.
Question.
Go ahead.
You mentioned oxygen and carbon dioxide. For oxygen, they have an oxygen. Do they have a similar thing for carbon dioxide?
There is a monitor for a transcutaneous carbon dioxide monitor, yes. But it happens, like I said, about 10% of the people, and we don't know of a particular clinical significance for that, so as of right now, we don't test that. So this is a very common picture to see. The reason this lady looks that way is because she's worried about her husband is not breathing. Not that he's snoring. But what you see is he's lying on his back, his mouth is open, he's obviously asleep, and she is really, really concerned. This person chose to fix the problem in a different way. So that works, but we don't advise it. So that takes us into sleep apnea. So obstructive sleep apnea is a very common condition. Like I mentioned, about 40% of people with COPD in general. In fact, it's estimated to be present in probably about 60% of the population as a whole. So it's a very common condition. What that is you stop breathing for periods of time, somewhere between 10 to 30 seconds, sometimes even longer than that, or sometimes just shallow breathing, and then you wake up to breathe. Frequently, this is associated with a drop in your oxygen level. So if you look at this, this is what we sort of see when we do sleep studies. This person here is breathing, and then all of a sudden there's no air movement at all for a good 20-30 seconds there. And then they wake up and start breathing again right there. So the graph right below that, you can see that the oxygen level, that's the graph in red, is dropping at the same time. And that keeps repeating itself, and you can see that this person stopped breathing about 3 times just on that page alone.
Does that ultimately lead to dementia?
There are studies, well, if you are sleep deprived, that means you're waking up a lot of times at night to breathe for whatever reason, or you just can't sleep, you get all the effects of someone who doesn't sleep well. And very common to that is just a cognitive impairment. A lot of memory issues, a lot of thought process issues can be slowed down significantly. As far as dementia per se, it has not been established as a cause, but there are concerns about it for sure. There is definitely a relationship between sleep apnea and developing strokes, and people can get dementia from strokes. Yes?
Is there any correlation with the people not breathing and the stages of sleep, like deep sleep or REM or anything of that nature?
Yes. So
Can you repeat the
Yeah,
question?
is there a relationship between the breathing pauses and stages of sleep? So there are two stages of sleep. There is REM sleep and non-REM sleep. REM sleep is short for rapid eye movement sleep, and this is the part of the night that we do most of the dreaming in. And to prevent us from acting out our dreams, our muscles become almost paralyzed. We can't move at all. And that includes all the muscles of the body, except for the heart, obviously. And during that, our muscle tone is so decreased that we usually see a lot of the breathing disturbances mostly during REM sleep. It is not unusual to see a sleep study with sleep apnea only in REM sleep.
There is such a thing in some industries that I was involved with, 4 hours of sleep. And the reason that the crew involved would take 4 hours of sleep, 4 hours of work. A good example of it is early orbit checkup. Satellites.
Can you
What
repeat?
is the effect of the long term of this? Usually it's only about 2 weeks, sometimes longer.
So the question is there any evidence to support having sleep in 4-hour blocks? Yeah. If we imagine that a person needs 8 hours of sleep, and that person only gets 6 hours of sleep, for example, over every day this person loses 2 hours of sleep. So at the end of the month, he loses a whole lot of sleep. So we call that a sleep debt. Now, a sleep debt is just like money debt. That means before you feel refreshed again, you have to pay off that debt. So fortunately though, you don't have to pay it back dollar by dollar or hour by hour. You can pay it back in much shorter. So it's estimated that for every hour of sleep that you lose, you can pay that back in a few minutes of sleep, of catch-up sleep. So for example, if you only sleep 6 hours tonight, tomorrow, just by sleeping like 8 hours and 10 minutes, you've caught up on what you lost the night before. So that's one thing. The other thing is, when you wake up in the morning, there is a neurotransmitter that starts getting released in the brain that helps you go to sleep. It needs a whole 16 hours for it to build up to a certain level to put you to sleep the next night. Now, if you fall asleep in the middle, you deplete that level of that neurotransmitter, and then you have to start from the beginning again. So that does help a lot of. That's why power naps help quite a bit. If you need to keep going for a couple of days, for example, taking a 10-minute nap here or a 15-minute nap here do really boost your energy, and you're able to do that. Problem is, though, you can't sustain that for a long time. So this is the anatomy of an airway. On the top is the nose, and right below that is the mouth, and between them you have the roof of the mouth, the palate. The latter part is the soft palate, which ends in the uvula right behind there. If you look at the way we breathe, this person is breathing normally. As you can see, air is going through the nose all the way back to the back of the throat. Now, that area in the back of the throat is really small. Normally, when we breathe, we all like breathing through our nose. We all do that right now. And when you're breathing through the nose, the mouth is closed. And you don't really open your mouth unless you have a stuffy nose or allergies or a sinus infection or something like that. Now, with your mouth closed, you'll notice that your tongue fits inside there perfectly. We almost think of the mouth like a suction cup holding the tongue in place. This is what happens with sleep apnea. The area in the back of the throat is quite narrow, so the air is not going in through the nose, so the person has to open up his mouth. When you open up your mouth, a number of things happen. One, air starts going in through the mouth instead of through the nose, so the mouth gets really dry. People will wake up with a really dry mouth in the morning. Also, the roof of the mouth starts vibrating, and that's where the snoring sound comes from. In addition to that, the tongue is no longer supported in place, so the bulk of the tongue is towards the back, so the whole thing slides back. and blocks the back of the throat even more. As you can see, the air just doesn't go through. That's when you see that breathing pause, when someone stops breathing. So sleep apnea results into a number of things. You wake up to breathe, so you have sleep fragmentation. Your oxygen level is low, carbon dioxide is high. That results into the daytime sleepiness because you wake up so much, but it's also the main reason we look at sleep apnea is the relationship to the heart. It causes a lot of cardiovascular issues. I found this slide was actually very nice. What it looks like is all the things that we see from sleep apnea. And as you can see, it's very strongly related to high blood pressure. That's been very well established. It puts you at risk for heart attacks and strokes and heart failure. As I mentioned to you earlier, the memory issues. So if you keep waking up to breathe, you will be cognitively impaired. There's a big link with sleep apnea and insomnia. As I mentioned earlier, a lot of patients with insomnia have that. They wake up in the middle of the night because of their sleep apnea. So to suspect sleep apnea, the most common that we see is just loud chronic snoring, and someone tells you stop breathing. And this is usually seen by the bed partner. Interestingly enough, most patients who have sleep apnea don't even know that they're doing that. You would see a lot of sleepiness at work or during driving. It is considered one of the most common causes of car accidents. You would see personality changes. People become more grumpy, more moody, memory issues just because you're not getting enough sleep. And of course, you're sleepy during the day. So when we do find sleep apnea, we need to look for that by doing sleep studies. And there's a number of ways of doing that. The two pictures on the left would be doing a sleep study in the lab. What that entails is going into a lab, spend the night there. We put a lot of wires on the body that tell us your sleep phase, how many times you woke up in the middle of the night, whether what stage of sleep you're in, and you just spend the night there and we monitor all that. We now have the ability of doing these studies at home. So the two other studies are the ones we use in our office. It's a small device, you take that home, sleep with it in your own home, and then bring it back the next day. And that will give us all the information we need. These home studies only help for sleep apnea. If we're looking for other sleep conditions, we usually have to do them still in the lab though.
Hello, question.
Oh.
You mentioned phases, sleep phases.
Yeah.
Are you going to go through that?
Can you repeat?
Asking about sleep phases.
Yes.
I can talk about them if you'd like. I wasn't going to talk about that in detail.
Yes.
So sleep phases, as I mentioned before, there are two different types of sleep, REM sleep and non-REM sleep. Non-REM sleep is divided into three subgroups, stage 1, 2, and 3. 1 and 2 being light sleep, and then stage 3 being the deep sleep. The way we all sleep is we go to sleep usually fall into stage 1 sleep, and then stage 2, and then we have a little bit of stage 3, and then we move from that into REM sleep. That cycle is about 90 minutes, an hour and a half. And it's not uncommon at all that people would wake up as they transition from REM sleep to non-REM sleep. And you repeat this cycle over every 90 minutes or so throughout the night. So what you end up having is short periods of REM sleep that get progressively longer as the night progresses. And every hour and a half, you go through one of those cycles.
Which one is the deepest?
No, actually REM is considered a light phase of sleep. The deepest is stage 3 of non-REM.
Non-REM.
Non-REM, yes.
That's the one,
Stage
if anybody wakes you up, you want to kill them.
I think all of them are important. To feel rested, you have to have good percentages of all the stages though. So they actually had a study, they put someone on propofol or Diprivan, which is the medicine that Michael Jackson died of. And what that does is that it really increases your stage 2 sleep. So people would spend most of the night in stage 2, and they're asleep. But when they tested them for how well rested they are the next day, most of them were not that rested. They were tired. So it's important to have all the stages. Yes?
What about dreaming during your sleep? Does dreaming keep you asleep or what?
Dreaming is a subconscious expression of certain imagery and ideas that you have. It doesn't keep you asleep or wake you up. It just happens as you sleep.
Can you change it by mental thought?
I don't know anyone who does that.
How about people who do not remember their dream at all, ever?
Repeat.
So she's asking about people who do not remember their dreams.
And you told that you should dream, you have to dream, I say.
So everybody dreams. As I mentioned, most of the dreaming happens during REM sleep. One of the characteristics of non-REM sleep is that it makes you forget. So if you dream and then have about 5 to 10 minutes of non-REM sleep after the dream, you will wake up not remembering your dream. So you would only remember it if your REM sleep was close enough to the end of the night, within about 5 minutes or so, that you still recall the content of the dream. Yes?
Okay, so when you're dreaming, okay, and you wake up in your dream, and you fall or something, there's a lot of different things that be caused by the dreaming.
So the question is, if you're dreaming and you fall as part of that dream. So, yeah. So that is
That's a
actually,
common thing, isn't it?
we do see it a lot. And the thing about that though is that, as I mentioned, when you dream mostly during REM sleep, and during REM sleep, your muscles are really almost paralyzed. You don't have any muscle tone. So theoretically, you shouldn't be able to move at all. You shouldn't fall. But it does happen, and there's a common condition that we see called REM behavioral disorder. I wasn't going to go into that, but I'll touch base on it. What that does is that in certain situations, that muscle tone doesn't go away, it remains. So in that case, that person would be dreaming and will be trying to act out the dream. That means, for example, if you're fighting with someone, you would start kicking and your arms moving around and talking and screaming and so forth. So this is a condition called REM behavioral disorder. And what that does is that it puts you at risk for injuries, obviously. There is a correlation between that condition and some neurological conditions such as Parkinson's disease, for example. So we see it very commonly in Parkinson's disease, and we see it in all other people who don't have. Some medications predispose you to that. There are some antidepressants that cause that. Alcohol can cause that as well. So these are, if someone does that, they should be evaluated.
He wants to know why.
Why does alcohol cause that? Alcohol is basically a sugar.
That's what he says.
Yes. The why part of it, I don't know, but we do see it in people who do drink a lot, yes. Yes?
What happens when your spouse is doing that? Should you help her?
What if she's falling?
So if that is happening, someone is acting out their dream like that, first, most important thing is, of course, safety in the bedroom area. We tell people to put up rails, put something around the bed so that the person doesn't fall. I have seen cases where people have really injured themselves by hitting their head on a sharp edge near the bed. Some people actually act out really complex maneuvers. They've left the house. I've seen cases like that. So if that does happen, that person needs to be evaluated by a physician because there are medications to treat that.
So I'm talking about if your spouse is active, all of a sudden it's dangerous for you. But should you touch her or console her, wake her up?
You mean at the time when it's happening?
Yes.
You could to prevent injury, but then she needs to be evaluated by a doctor. Yes.
Doctor, how accurate are Fitbit devices? I wear a Fitbit device every night, and I see how much I have deep sleep and REM and light sleep and so forth. How accurate are they?
They are getting better and better as time progresses. So the current generation are actually very close. That being said, though, they depend on a motion sensor inside the device that detects the movement, and with certain formulas they have, they can sort of estimate that this is REM or non-REM. They can't tell more than that. they're reasonably accurate, but I wouldn't use them to diagnose anything.
Doctor,
Yes.
I have a clinical question for you. It was shown in a CAT scan that I had that when I'm lying flat, my trachea flattens out. So how does that affect my breathing at night? And is it related to COPD or other breathing disorders?
I would say that's more of a COPD issue. We see it with COPD when the trachea flattens out. Tracheas are covered, have cartilage rings that are supposed to keep it nice and round. So if it flattens like that, that's more of a COPD issue. I don't think it's related to the sleep. Just when they did a CT scan, you happen to be lying down, but it's probably like that all the time.
Just lying down.
It's probably present like that all the time,
Oh.
but because they did the CT scan when you were lying down, that's what they saw. Yes, sir.
Recently, I think maybe a point of interest, I'm sure most of us will have nothing to do with, but I read there is a knowledge nowadays. If you wake up a person sometime during his sleep, you will have the best brainstorm ideas. Have you heard about it?
Can you repeat that if you understand it?
If you wake up someone in the middle of the night, you will have the best amount of ideas.
Right. But there are some companies or institutions that use it with their personnel.
During the awake time, we built in us is some sort of suppressive habits, I guess, that prevent us from acting a certain way or thinking a certain way. So for example, you may not like someone, but you will not act on that or verbalize that during the awake time. But it is thought that at night, this inhibition is removed. So you're allowed to think freely.
Open mind.
You're allowed to think freely, and you're allowed. So if you wake someone up during a REM sleep period when they're actively dreaming, they will still remember the content of that dream, and they can narrate that idea, and that's some ideas come from there. I don't know the clinical significance of that, though. I don't know if that can be used in real life, though. Yes.
What about when someone is sleepwalking? Is this when they are dreaming?
So, yes.
Repeat.
What about dream walking? Sleepwalking. Yes, sleepwalking is something we call parasomnia. So these are the abnormal movements that happen at night. It could be one of two things. So it could be, as you mentioned before, the REM sleep disorder. I said I've seen some people really do complex things where they get up and walk. And that comes out of REM sleep. Or it could be during non-REM sleep, some dreaming during non-REM sleep, and you get up and walk as well. That one, if it is during non-REM sleep, it's a really benign condition, except that it's a nuisance. We usually see it in kids. It's very common in kids. Most people outgrow it by the time they're mid-teens, but we do have people in their adulthood continue to do that. If I do see an adult with sleepwalking, I would test them. I would do a sleep study to see which phase it came out of and what is happening at that time.
So if someone is sleepwalking and you tell them, go back to bed, and they go back to bed, but they're able to understand what you said, but they're still asleep, and the next day they don't remember at all?
So the question is, if someone is sleepwalking and you tell them to go to bed and they understood that and went back to bed, what happens then is the transition from sleep to wake can sometimes be a little fuzzy, what we call confusional arousals. So you transition from sleep to wake, some of the effects of sleep are still there, but you're awake enough to be able to interact with your environment. So that person is awake, by definition. And then the moment you go back to sleep, as I mentioned with remembering the dreams, if a few minutes of non-REM sleep pass by, you will forget that you woke up. So to that effect, I'll tell you that, as I mentioned, when you transition from REM sleep to non-REM sleep, we all wake up. We all wake up at least 3 to 4 times a night. We just don't remember it. So the person who says, I sleep through the night, in reality, that person is waking up 4 times at least. He just doesn't remember waking up.
Okay.
Yes?
This question may have been answered, but I recently have been waking up, and it was as though what I was dreaming or thinking about, I find my hand reaching to do what it was. If that makes sense?
So, yes. So we call that dream inertia. Do you know what inertia means? Inertia means like if you were to push a pencil on the table and then let go, the pencil keeps moving. So what you're experiencing is parts of the sleep sort of progressing a little bit into the awake. And that's not unusual.
Let's hold the rest of the questions, you guys. The doctor's never going to get through his presentation. There have been some great questions, but we got to let the good doctor get through the slides, then we can ask questions.
The treatment for sleep apnea is one of 3 things. Either a CPAP machine. Does anyone here use one? Yeah. So CPAP is and the BiPAP is also a similar machine that sometimes we use for COPD as well, but that is a positive pressure machine. So normally we breathe by negative pressure, so we create a vacuum in our chest and air rushes in. CPAP actually forces the air in under pressure. There are some dental devices that also help, and surgery.
Are they any good, the dental devices?
It depends on the severity of the sleep apnea. For mild to moderate cases, yes, it works very well. These are the common ones on the market. Yes.
What is the difference between CPAP and BiPAP?
What is the difference between CPAP and BiPAP? CPAP is one constant pressure all the time, whereas BiPAP is 2 different pressures, one while you're breathing in and one while you're breathing out. So these are common devices, CPAP machines. These are the 2 commonest ones on the market, but there are a number of others. And they do make some really small ones as well for travel, like the one on the corner over there. These are the masks that everybody's afraid of.
Hate it.
They're not that bad.
If you do hate it, then you may want to consider to a different one, because some of them are very comfortable. So it's a different, there's hundreds of masks out there, and you just need to find the one that works. That biggest one over there, we used to call the moon mask. Surprisingly, as big as it is, it's actually quite comfortable. Yeah. But most of the time when I start someone on CPAP, I start on the really small ones. And these are like almost like nasal cannulas for oxygen. They fit inside the nose. And as you can see, that person over there is actually reading with an arm. So they're quite comfortable to use and very small, and they don't confine like the others do. What these do, as you can see, under pressure, the back of the throat that was closed before from sleep apnea is now wide open. The before and after picture is very obvious. Before, the patient was totally obstructed, and then after that, it just opened up. The dental devices, there's, again, hundreds of them on the market. There are some that you can buy over the counter, and there are some that you get through a dentist. They work reasonably well in the mild to moderate cases, and I've had a few really severe sleep apnea using them as well. The way they work is that they fit snugly on the teeth, and then they push the jaw forward, as you can see in that picture over there. And by doing that, they relieve the pressure off the back of the throat. And then we have a whole number of surgeries. I'm not going to go into those, but there are a bunch of surgeries that can be done as well. That's it. Okay, melatonin.
Believe in it or whatever.
Melatonin is a very interesting medication. The idea behind sleeping pills is that when you take them, they relax you. They are supposed to sort of shut off the anxiety and the muscle tone decreases, everything sort of calms down. They're downers. Melatonin works in a different way. Melatonin is a medicine that goes in there and tells the brain what time it is. Essentially, it tells the brain it's nighttime, and then allows the brain to function what it does at night. So for example, if you were to give melatonin to a nocturnal animal, it actually stimulates them, it wakes them up. So for humans though, it does the opposite, where when you take it, it's supposed to tell you it's nighttime and allows the brain to function well at night. The problem with a lot of the melatonin that's on the market is that the dose is very variable. So you could get a box that says 5 milligrams, but you have really no idea because melatonin is not governed by the FDA. So you have no idea. It's considered more of a supplement than a medicine. So you really have no idea how much is really in there. That's one thing. The other thing is
Made in China?
even after you take it, the amount of melatonin that actually gets absorbed is very variable from person to person, and the part of that is able to access the brain is also very variable. So it's there's no strict rule about or science behind the melatonin, but it does work. It does have a little bit of a sedating quality to it. If someone were to take melatonin though, it's usually thought to take it about 2 to 3 hours before you go to sleep to allow this process to go through. Go ahead.
My wife was referring to the Chinese. Actually, I would like to refer you to the Chinese herbs that they claim help you to sleep.
The only other thing available other than melatonin is valerian root, and that contains a whole lot of other chemicals in there. We don't know exactly what helps sleep out of the valerian root, but these are the only two. In addition to that, there's a whole bunch of other medications that have a lot of claims behind them, but none of them have been thought to be right.
We'll take one more question, and then if you have additional questions, you can ask the doctor after we finish. Sarah.
So sleep paralysis, is that when you wake up in REM, or is it something deeper than that?
So sleep paralysis is a condition where you wake up, but the effects of REM sleep are still persisting. Again, this is the inertia part of it. The loss of muscle tone during REM sleep continues into awake a little bit. We normally see it in children, so it can happen in children a lot. It happens very frequently in people who are sleep deprived. So if someone has a lot of sleep paralysis, you have to figure out there's something wrong with their sleep. We see it very commonly in narcolepsy because these people are sleep deprived. But it's really, as much as scary as it is, yeah, it doesn't really cause any medical issues.
Thank you, Doctor.